and also the trochleoplasty and trochleodysplasia. So trochleoplasty, indication and techniques. So you have to look at that because this is, you test the patient, you see he has a permanent patellar dislocation. These are his X-rays. You see the patella is on the lateral side. So what to do with that? And when you know that this patient is 17 years old, and this is his knee, of course, that you can do an MPFL. The MPFL will not work too much, of course. And you see that also the cartilage is not really good. Okay. And you have seen that I have opened the extensor mechanism because he had probably a short quadriceps because he's dislocating in flexion. That's very important. The story starts in 1802 when this Parisian surgeon, Richiede, did a chapter in English in a book, and he said that he related the patellar dislocation to some abnormalities on the femoral side. Three patients, 3 cases of dislocation, and he said that the external condyle of the femur may be depressed and may be the cause of it. Fantastic. 1802. And then 1890, this British guy, Benton Pollard, did the first deepening trochleoplasty. Unbelievable that an English did that. But he did. And Douglas Drew described this Benton Pollard procedure, and he said that he was speaking about genevism as a secondary factor of instability. He was speaking about the weakness of the vastus medialis, and he was speaking about the abnormality of the femur. So people described that a long time ago, for sure. So always go back to the literature because it's always interesting. So the dislocation is always related to anatomy, okay? And native anatomy, as you have that, so you see that these are not, but they are painful syndrome, huh? You agree with that? Huh? But it also could be done by a iatrogenic surgery. And for example, this patient had an LB procedure, stupid procedure. It creates a trochlear dysplasia, a high-grade trochlear dysplasia. So this is the relationship between the anatomy and the dislocation. And the indication for trochleoplasties are that indication. That's why I'm not talking about arthroscopic trochleoplasties because this is impossible to do that on arthroscopy. So back to 1987. They found that because they start to use a systematic true lateral view like that, and they have seen the crossing sign, the depth of the trochlea, and the bump, la saillie in French. And this is very important, and this is the first classification of the trochlear dysplasia. And the bump, la saillie, the supratrochlear spur, is really something important because if you look to the patellar dislocation group, the bump is between 3 to 5 millimeters, which is huge. And if you go to the control group, it's only 0.1 millimeter. So it's the trochlea is flush with the anterior cortex. So here again, in 1998, when I changed the classification, we use slice imaging and X-rays, and we describe those 3 points, describing the different type of classification of the trochlear dysplasia. So you have to understand this double contour here. It is the subchondral bone of the medial facet here. This is very important to understand, and you see that you have no medial facet at all. So high-grade trochlear dysplasia will create a maltracking on the horizontal plane because you have a permanent subluxation. You increase the stress on the cartilage, on the patella side. You increase the impingement when you flex the knee, the patella impinge the supratrochlear spur, so you have some cartilage damages, mostly on the trochlear side, not too much on the mostly on the patella side, not too much on the trochlear, because the trochlear is not loaded. So it's not really, when you speak about arthritis damage on both sides. Here you have some terrific cartilage damages on the patella side, but the trochlear is okay. So sometimes you can extend the indication of a trochleoplasty even if your cartilage is not so beautiful on the trochlear side. This is the study we have done with Andrew Amis with a normal knee. This is the ML displacement of the patella. This is exactly when you have a trochlear, when you create a dysplasia, you see that the patella is going medial, lateral, going everywhere. And this is when we have done the trochleoplasty. You see that the patella is again very, very clear in the groove. There is only this one, this patient, which is not very good. It's because it's Andrew Amis who did the trochleoplasty. So he's an engineer. How to correct the anatomy? Trochleoplasty, you can do IB procedure with a fantastic book that I have seen in the Lezioni library. Fantastic, unbelievable to see this book. You can do a closing wedge osteotomy, which you remove the bump but you don't change the shape of the trochlea. And then you can do the best, the deepening trochleoplasty, where you recreate the groove and you do a proximal realignment. So this is the open deepening trochleoplasty. And this is perfectly the best indication. When you have this bump, when you have the double contour, when it's a type D. This is definitely the best with the type B, because the type B you have this prominence. The goal of the trochleoplasty is also to remove that. So best indication is in type B and D to remove this convexity and to our back to concavity and congruency for sure. So the technique and the indication will be to remove this abnormal tracking, and as soon as you have this abnormal tracking, this is a good indication for trochleoplasty, definitely, because you always have a high-grade trochlear dysplasia. The sulcus angle will give the stability. Just to understand you, if you want your MPFL to work well, you have to position your MPFL well. Okay, so you take the fluoroscopy, you do everything, you put the best MPFL you can do. You're very happy with that, and félicitations. You have find the right spot to put your MPFL. If you don't correct the trochlear dysplasia, the wrong side is not the femur, it's the patella, because the patella is too much anterior compared to the MPFL. So it is exactly like if you have a wrong placement of your MPFL, and you will get an MPFL failure. So look at that, it's so beautiful. The cartilaginous trochlea, okay, this is what you will change, but also you need to remove that. And look at this video. Oh, it's so beautiful. You see? And you see this big prominence, and you understand exactly why the trochleoplasty is well indicated to such specimens. So this is the video where you will see that we do a mid-vastus approach or a transquadricipital approach. I would say that I do mostly transquadricipital approach now, because I can do a little bit of VMO-plasty too. So you will mark the groove line, the native groove line, the medial and the lateral facet. And this is exactly where you have the condylotrochlear line and condylotrochlear line on the medial facet. And you see that there is nearly no medial facet on this patient. And then, when you have done that, you have measured DTTG on the MRI or on the CT, and you mark your new groove. So this is a proximal realignment that you will do. For example, here it's 10 millimeter. After that, you remove the cortical bone all around the trochlea, but you have to go above the trochlea, more proximal, just to find exactly where you have the anterior cortex, because your trochlea has to be flush with the anterior cortex. So you have removed the spur, then you take this guide that you will see, a guide from Artrex, and with this burr, you do some tunnels all around the trochlea, and you really have to go till the top of the notch, because the whole trochlea should be detached. And what is good with this guide is that you keep at least 5 millimeter thickness of cartilage, so no risk of necrosis. No risk of necrosis. I never had any risk of necrosis. So while I have done that, then with like a compass and with a high-speed burr, you will clean the cancellous bone, but you remove the bone on the femoral side, not on the trochlear side. So it is a real osteotomy. Then you cut the cartilage with your knife, not to damage it. Then you take the osteotome, 45 degrees angulation. If you go straight like that, you will break the trochlea. So you have to take 45 degrees angulation, and you start from the top, proximal to distal, and up. Oh, fantastic! Look at that. Oh, so beautiful. Every time I see that, I'm so impressed. You're not impressed? Oh, you're so impressed. And then you cut the lateral facet. Okay. Most of the time you don't have to cut the medial facet. Then you see exactly where your trochlea is. And you will be able to adapt the amount of deepening you want. So you see, for example, here it's not exactly flush with the anterior cortex. So I will take again the burr and remove some bone, cancellous bone, and now it's exactly flush with the anterior cortex here. And I do the same on the lateral facet. Then I use my pusher to correct and do the new trochlea. I put one swivel lock with Vicryl number 2, absorbable suture. I don't like the big tips. And then I put one on the medial and one on the lateral facet, and I can move a little bit where, and I put the anchor where the compression is the best, okay? And I put one anchor. On the lateral facet, you can lift a little bit the lateral facet, and sometimes you need to graft it a little bit, so you will increase the correction of your trochlea with a little bit of graft, and it works well, but it's not always necessary. And then you fix the trochleoplasty. So at the end, you will end up with a nice trochlea with no more bump, which is the goal for sure. So this is pre-op and per-op and the final trochlea. So you see that you really correct the shape. So what you can get with the trochleoplasty, if you do primary or secondary, it's definitely different, and the results are much better in the primary indication. You can do a proximal realignment of average of 9 millimeter. You will correct perfectly the tilt, and the tilt correction is the best, because the tilt is directly correlated to the shape of your trochlea. And in our midterm study, we had 2% of stage 1 or 2 Iwano arthritis, which is not arthritis, it's a remodeling of the PF. If you go through the literature, and now we have a lot of articles about trochleoplasty, and that's very fine. You see typically that the results is highly dependent on the amount of spur and the amount of proeminence. So it means that you need to correct that, and these are the good indications for doing a trochleoplasty. Remember this picture? This is the best indication for a trochleoplasty. The redislocation rate is lower in that population, which is highly unstable, and we have different articles on that. So, in conclusion, this is a mechanical correction. It is definitely like a nostro, and you can restore the balance of the contact pressure for sure. And we didn't see any increases of osteoarthritis. Should that prevent from any arthritis? We cannot say that at all, of course. And for sure, the arthritis in the future is mostly due to the curve dislocation. Like an ACL, when you get an ACL, it's no more the Thank you.